spinal cord is a part of the central nervous system, which is cylindrical continuation of the central nervous system beyond medulla. We know the brain, prosencephalon, mesencephalon, rhombencephalon, that means forebrain, midbrain, hindbrain. Hindbrain is continued as pons, medulla, cerebellum. So the medulla is continued. So where we can get the extent, it is beyond the medulla, is the part beyond medulla. So continuation we extent is the upper border of the first cervical vertebra, that is the atlas, and we know there is foramen magnum, so it is that creates the junction between the medulla and the spinal cord. And also we know there is a odontoid process, or there is odontoid process or dens of the second cervical vertebra, which is called axis. The midpoint of the odontoid process also denotes the junction between the medulla and the spinal cord. So it is the cylindrical continuation of the central nervous system. Okay. Now we know there are several structures in our body which has got 45 centimeters length. That is, one of them is the spinal cord, another is, the vas deferens or ductus deferens, standard adult femur, the length of the standard adult femur, that is also 45 centimeters in length. So similarly, this is the extent, and this is the upper extent is the upper border of the atlas. Okay. And the lower extent, we know the spinal cord ends in a lower extent, this is the L1, and we get a tapering end. Okay, we get a tapering end, the lower end, which is called conus medullaris. Conus medullari. So upper and lower end is the L1 vertebra, that is the transpyloric plane. We know that is a transpyloric plane. There are so many, that is pylorus, hilum of the kidney, fundus of the gallbladder, and also we can get the lower extremity of the spinal cord. Actually, in early fetal life, the spinal cord is continued throughout the vertebral column. Throughout the vertebral column, the spinal cord is continued in early fetal life. Then what happens? There is disparity in growth, where the growth of the spinal canal or vertebral canal becomes more. So, just after birth, we get the spinal cord remains up to the level of L3 vertebra. L3 vertebra. Okay. But gradually, due to more and more growth of the vertebral column, and we get the lower extremity is up to the L1 vertebra. Now, from L1 vertebra, the spinal cord is continued. Okay, we can get a filamentous structure, fibrous structure, which is contributed by, we know there are three coverings, dura, arachnoid and pia. The pia covering is continued as Filum Terminale. So that we can find this is the Filum Terminale. Okay. The green one and the red one as a whole, this is the Filum Terminale. And it is continued up to the coccygeal vertebra. Either first, the dorsal aspect of the first or the second coccygeal vertebra, it is continued. This is called the Filum Terminalis, which is contributed by the pia matter. Okay. And that too, that Filum Terminale, the upper part, green one, you can see that is called the Filum Terminale internum. And the red one you can see here, that is the Filum Terminale externum. Actually, that the internum part, actually here we can get the coverings of dura and arachnoid up to the level of second sacral vertebra. We know the arachnoid matter ends at the level of second sacral vertebra. Okay. Arachnoid covering ends. So that part remains within the under the coverage of the arachnoid and dura. So that part is called the Filum Terminale internum, and this part is without any layer, without any coverage. So it is called Filum Terminale externum. Filum Terminale internum is 15 centimeters, and that is 5 centimeters. Now, so Conus Medullaris, we know that is this part is called the Conus Medullaris. Now we can find there are two enlargements of the spinal cord. One is present at the cervical region, another is present at the lumbar region. Why? We know there is emergence of brachial plexus. So neural elements. So it has to contain so many neural elements. Brachial plexus is we can get C5 to T1. Okay, C5 to T1. Similarly, the lumbar plexus L1 to L4. Okay, and there is also that L4, and from there we get the part of the L4, L5, S1, S2, S3. They form the sacral plexus, and then we are getting coccygeal plexus. So these neural elements, so we are getting the emergence of the nerve fibers. So neural element is more in that region. So in the cervical region and in the lumbar region there is swelling. Okay. So that is called cervical and lumbar enlargement. So we know C4 to T12, one segment above and one segment, we have to include another. That is C5 to T1, just include the previous one and the next one. So you can remember that one. So similarly here you can also remember the L2 to S3, that will also cover up the lumbar and sacral plexus. Okay, S3. Now the coverings you know, that is the brain and the spinal cord is covered with meninges. Meninges contains dura, arachnoid and pia. Similarly, we are getting the arachnoid, dura, arachnoid, and we are getting this subarachnoid space, arachnoid and subarachnoid, and pia is intimately attached, and here we are getting a dura mater, and outside the dura mater we are getting epidural space. Okay, and this is the vertebral column, and most inside we are getting the spinal cord, and which we are getting the anterior horns and posterior horns. The anterior horn is rounded, whereas the posterior horn is slender and elongated, the posterior horn. So here we are getting the nerve fibers are coming from this part. There is the anterior roots. These are the posterior root. Okay, so 1, 2, 3, 4. We can get 4 nerve roots in each segment. Okay. So anterior nerve cells and posterior nerve roots. So there are 4 in numbers. Altogether we can get. So in brain we are getting outer gray, inner white, and inner gray, outer white in the spinal cord, that is the reverse one, and in the center we are getting the central canal, and here we are getting the covering of the pia, and this is the anterior median fissure and posterior median sulcus. Okay, this we can get this fissure which is called anteromedian fissure, and posterior one is the very small one, that is called sulcus. Fissure is whose depth is more. Okay, and within the anteromedian fissure we can see the encroachment of the pial matter, and this is called an linear pial matter we can get, which is called linea splendens. Linea splendens. Okay. So there are several derivatives of pia. One is the linea splendens. So this is the, and pia we know that is intimately attached to the canal. So there is a spinal cord. Okay. And we are getting so many things, so many nerve roots we can get, and we are getting, this is another derivative coming out from the pia. Okay. And which has got what is the pattern? It is tooth-like. Tooth-like. Dentate. Tooth means dentate. Okay. So we can call it as a denticulate ligament. Actually, they help in attachment of the spinal cord to the vertebral column. So this forms a support. So pia not only covers, but also the modification of pia is ligamentum denticulatum. So dentate ligament or ligamentum denticulatum which are present, and they help in anchorage of the spinal cord to the vertebral column inside, within the vertebral column. What are the supports of spinal cord? One is the vertebral column. We are getting the vertebral column here. So they are the important support, and also this ligamentum denticulatum which is present. Okay, there are 21 pairs of teeth-like. You can keep 21 pairs of teeth-like projection of pial matter, which helps in anchorage of the spinal cord. You cannot take out, because unless and until we cut this ligamentum denticulatum, we cannot take out the spinal cord from the vertebral column. Now we can find there are some the anterior roots, posterior roots we can get, so many roots. So we can see it here in the viscera, and this is the continuation of the Filum Terminale. Now this is the what I was saying, that is the linear splenius, that is a thickened part in the anteromedian fissure. Okay. So this this picture shows the lumbar puncture. Very important clinical procedure we perform in the clinic or during spinal anesthesia. So to perform that, we have to have the knowledge of the anatomy, because we know the lower limit of the spinal cord is the conus medullaris, from where only the pile matter and the dura and arachnoid, they are also continued, okay, up to the S2. So from L1, lower border of the L1, we are not getting any spinal cord. So we cannot, so if we put a syringe in the vertebral canal, it will not injure the spinal cord first, because the lower limit is over. Lower limit is at the level of L1. So preferably we can perform in the space between the L1 and L2, but preferably we select L3 and L4. This is one step down. Here we can perform, we know this is the subarachnoid space where we can negotiate the lumbar puncture needle in this space, and we can take out the cerebrospinal fluid. That has got both the diagnostic and therapeutic effect. Diagnostic means in some meningitis, like tubercular meningitis, bacterial meningitis, we can diagnose. So there are actually the clear, actually CSF is absolutely a clear fluid like water. So if there is any turbidity or any presence of any other material like blood, so we can diagnose the subarachnoid hemorrhage, we can diagnose the bacterial meningitis, so and so. So this is the, so here the knowledge of anatomy is needed, because we know this conus medullaris, this or the lower limit which tapers and forms a, and we can get the lower limit triangular area which is called conus medullaris. Okay. So there are some, I am not going into the detailed epidural space, subdural space, subarachnoid space. Just remember the epidural space, these are very important for the anesthetist. Epidural anesthesia is done. The subarachnoid space, we can, this is the area where we know we can get the cerebrospinal fluid, and we can also get the cerebrospinal fluid within the central canal. Okay. In the lumbar cistern means in the lower part of the spinal cord, we can get a cistern-like area. That is, what is cistern? The subarachnoid space is voluminous. We know there are so many cisterns, we got it in our brain. Cistern means the subarachnoid space. That means we got the pontomedullaris, cisterna pontomedullaris, in between the pons and medulla. Oh. And pontine cistern, we got it over the area of the basilar artery. We are getting the cistern, means there is voluminous subarachnoid space. Interpeduncular fossa, we got it. So there we also get the area where we can get too much of cerebrospinal fluid, that is called the cisterns. So similarly, a cistern is also present where we can get in the lower end of the spinal cord. So that is called lumbar system. So what we can find, vertebral segments and the cord segments are not synonymous, because spinal cord is above, it ends in L1 level. So in cervical region, the cord segment is one segment, it is placed one segment above. That means in the cervical segment, that means in the cord segment, that means C5 cord segment is placed at the level of C4 vertebra. Because the lower end, at the lower end of the L1 vertebra, spinal cord ends. So it is lifted. So in the cervical region, it is lifted one level above. That means in the fifth cord segment is placed at the level of fourth cervical vertebra. Similarly, in the thoracic region, in upper thoracic region, it is two segment above, it remains. In lower thoracic segment, it remains in the 3 segments above. In the lumbar region, the cord segment remains 4 segment above. That means, suppose this is 4th lumbar segment. It is placed, that means at the level of, if you go 4 above, that means at the level of T12. Okay. 4th lumbar segment is placed at the T12 vertebra. Okay. And in the sacral segment, it is 6 segment above. So that is a important criteria you can know. Now we can get the interior, and here we are getting the anterior gray column, posterior gray column, and from here we are getting the anterior nerve roots, which is the motor nerve roots, and from the posterior end, that is the sensory nerve roots. Okay, and here we are getting the sensory, that is the posterior root ganglia. These ganglia, actually they remain in a linear fashion, as a linear fashion, by which we can also determine whether it is the anterior aspect or the posterior aspect of the spinal cord by looking at the spinal root ganglia. Okay. So this anterior motor root and the posterior the sensory root, they joins to form the spinal nerve. So spinal nerve basically is a mixed nerve, and here we can get the anterior motor root and posterior sensory root. We can get. Now this is we can get so many the fissure, that is the deep fissure, which is called anteromedian fissure, whereas this is the posteromedian sulcus. Okay, and on lateral side we can get other 2 sulci, which is called posterolateral sulcus. So anteromedian sulcus, and within the, so what we can get, the anteromedian fissure and posteromedian sulcus and posterolateral sulcus. And here in the posterior part, we can get one septum, which is called posteromedian septum. And here also we can get another septum, which is posterolateral septum. And there is another septum in between the postero-intermediate septum. So whatever might be, you can remember that one. That is the at least you remember anteromedian fissure and posteromedian sulcus and posterolateral sulcus, and posterolateral sulcus, through which we get the rootlets of the sensory nerves. And we are getting outer white, inner gray and outer white matter. That means there is the outer white column and inner gray column. Inner gray column means there are so many. What is the meaning of gray matter and white matter? White matter means there we will get the nerve fibers. Only the nerve fibers. The pyramidal tract. The motor neuron is forming the gray matter. Pyramidal cell body or the soma, they are forming the in the outer cortex. What we will get? The gray matter, that means within we will get the cell bodies. Okay. Similarly, in the gray column, we will get the gray column. Why? Because this we will get the so many cell bodies. Okay. And this anterior, the whole white column is divided into anterior, posterior and lateral white columns. Anterior white column is bounded in between two anterior horn cells. Similarly, posterior white column is bounded between these posterior horn cells. Okay, in between two posterior horn cells. And in between anterior and posterior horn cells, we are getting the lateral white column. Okay. So there are so many fibers that will either pass, either they will pass downwards or some fibers will pass upwards. Through the posterior white column, we can get the sensory fibers. And most medially it is called, or the fibers are called the fasciculus. Fibers or fasciculus. Most medially we are getting the fasciculus gracilis coming from the ground, just remember. And on the lateral side we will get the fasciculus cuneatus. So there are the sensory fibers. They will end in gracile nucleus and there is cuneate nucleus in the posterior aspect of the medulla. We get those two elevations. Okay, we will find. So these fibers will end there. Okay, the first order neuron will end there. Okay, so these are some. So posterior gray column, they are actually they contains the ascending nerve fibers. Okay, sensory nerve fibers. Whereas in the anterior part we can get descending fibers, the pyramidal fibers, corticospinal fiber, anterior corticospinal fibers. They are anterior. Upper motor neuron. Okay, they are passing through this anterior white column, anterior spinothalamic tract, anterior corticospinal tract. Okay. Similarly, in the lateral white column, we can get both ascending and descending. Like anterior corticospinal, similarly there is lateral corticospinal tract we can get here. From the pyramidal fibers, they are coming down. Majorly they are coming through the anterior white column as anterior corticospinal tract. But some of the fibers can descend through the lateral part, which is called lateral corticospinal tract. And also some fibers which carry the pain and temperature. Lateral spinothalamic tract, which we will get from this area. Okay, actually they across the area, okay, and ultimately they ascends through the opposite white column. That is lateral spinothalamic tract. Similarly, in the ventral spinothalamic tract is there. So I am just giving you an idea. There are so many, like rubrospinal tract, tectospinal tract. There are so many tracts. So just remember, there are some ascending and descending tracts or fibers are going through the white column. And there are some intersegmental fibers, okay. From here to here, they forms a reticular pattern, net-like pattern, which is called formatio reticularis. They form a formatio reticularis. So, what I was saying, the spinal cord segment varies. You can find in the cervical region, one vertebra above, in upper thoracic segment, 2 vertebra above, in lower thoracic segment, 3 vertebra above, okay, in the lumbar segment, 4 vertebra above, and sacral segments, that means 6 vertebral segment, 6 vertebra above the cord segment. Now, we can find this is what is called Cauda Equina. What is Cauda Equina? From the Conus Medullaris, we can get the continuation of Filum Terminale. We can, the central one is the Filum Terminale, and along with 4 lumbar nerves, we can get second, third, fourth, 4 lumbar nerves on either side. 5 sacral nerves from on either side will come out, and 1 coccygeal nerve. They will come out and they will pass through the respective spinal foramen, and they forms a pattern, a particular pattern. We have seen that the tail of the horse, so it looks like a tail of the horse. So it is called Cauda Equina. Equine means horse. Ledge. Ghoral ledge. So it is called Cauda Equina. So it looks like the tail of the horse. So it is called Cauda Equina. So just remember 4 lumbar nerves. The first lumbar nerves comes out independently, but the other ones comes as a whole. 4 lumbar nerves, 5 sacral nerves, and 1 pair of coccygeal nerve. They altogether they forms the Cauda Equina. Okay, and they come out through the respective intervertebral foramen. Now, internal structures already I have. So, there is region to region, there is the modification of the morphology. Like in the cervical, this is the cervical region. In the thoracic region, this is the lumbar region. You can see in the lumbar region, the anterior horn cell is very much bulbous and rounded. And here it is broad, but broad and massive. And in this area, even the anterior horn cell, it is slender in the thoracic region. So it changes from. So how we can identify the above and below? By looking at the lower level is determined by the Conus Medullaris, apical part. tapering end, we will get the conus medullaris below. In upper part, we can get this cord segment, the cut out segment. Anterior and posterior, the anterior one is bulbous and posterior one is slender. Okay. And anterior posterior also we can identify this fissure, anteromedian fissure and posteromedian sulcus. Okay, by which we can identify. Now about the important one, that is the blood supply. In the anteromedian fissure, we can get the anteromedian fissure. Here we can get one artery which is called anterior spinal artery. Actually, from the vertebral artery, two arteries are coming down from vertebral arteries. Okay, vertebral artery, they are coming to anterior spinal artery. They come and join to form one artery, and it is continued within the anteromedian fissure. Okay, which is called anterior spinal artery. Similarly, we are getting the posterior gray column or posterior horn, okay, through which the posterior nerve roots are coming. This is the anterior nerve roots, and on either side we are getting one artery. Okay, they are the posterior spinal artery. The posterior spinal artery actually comes down like this on either side and divides. Posterior spinal artery is also coming from the same vertebral artery. Vertebral artery we get in the cervical region. We are getting the foramen transversarium, and we can get this. This is the vertebral artery. Okay, vertebral artery, and these two vertebral artery joins to form the basilar artery at the lower border of the pons. Okay. Before that, it gives anterior spinal and posterior spinal arteries. These posterior spinal arteries, they are also coming from the vertebral arteries. Okay. So they are, the posterior spinal artery divides into two branches, one in front and one behind the posterior root ganglia. Okay. So this is the primary arterial supply of the spinal cord. But in the cervical region, in the thoracic region, in the lumbar regions, there are so many other arteries which can supplement or enhance the blood supply of the spinal cord. They are called the radicular arteries. Radicular arteries. Like in cervical region, the deep cervical artery. In thoracic region, posterior intercostal artery. Posterior intercostal artery. In the lumbar region, the lumbar arteries, L1, L2, L3, L4, so many arteries are there. So, from there, the branches are entering into the vertebral column, and they can enhance these arteries, the spinal branch of the segmental arteries. They enhances the or increases the blood supply of the spinal cord. They are called the segmental arteries or the radicular arteries. And they are coming with passing through the spinal nerves and divides into the anterior spinal and posterior radicular arteries. And the anterior radicular arteries are very thick. They are called the Arteria radicularis magna. Arteria radicularis magna. Arteria radicularis magna is nothing but the anterior radicular arteries which are very thick, and they supplement the blood supply. Majorly by the spinal cord is supplied by anterior and posterior spinal arteries, and they have been enhanced. The supply is enhanced or supplemented by the radicular arteries, anterior and posterior. Anterior ones are thicker, they are called arteria radicularis magna. Similarly, we can get three longitudinal veins, one along the anteromedian fissure, one along the posteromedian sulcus, and one behind the motor root, and one behind the sensory roots. 1, 2, 3, 1, 2, 3. So they be three anterior and three posterior longitudinal venous channels are formed. Okay, and they unite at the base of the skull. Okay, base of the skull, and forms the vertebral venous plexus, and ultimately enters into the foramen magnum and enters into the inferior petrosal sinus. We know there are dural venous sinuses. Okay, so inferior, superior, inferior petrosal sinus, cavernous sinus, there are so many sinuses which are called the dural venous sinuses. So we can appreciate why the cancer prostate can enter into the dural venous sinuses, and it can affect the brain through this vertebral venous plexus. Okay, so there are some vein of Batson which directly enter, which are valveless, which enters into the vertebral canal. They are valveless veins which are called the veins of Batson. Answer is veins of Batson, vertebral venous plexus, dural venous sinus. You will get these three words. If you can write, you will get full marks. Veins of Batson, vertebral venous plexus, dural venous sinuses. Examiner will not see anything. His or our eyes are absolutely fixed about these 3 points. Veins of Batson, vertebral venous plexus, and dural venous sinus. You will get the full marks. বেশি কিছু লেখা লাভ হয় না। আমার বাড়ি থেকে গেছে, ওখানে গেছিল, ওই বাড়ি থেকে গেল, এই বাড়িতে নো। So this is the there are clinical integration, you know, there are upper motor neuron, and clinical basically the functional aspect, which is actually dealt by that will be dealt in your physiology class. I was in the canteen when your head now, that is Dr. Subhashish, was talking with me. Sujita, you just utter about the details about the anatomical aspect. Okay, so that I can teach them nicely about the functional aspect. So there are upper motor neurons, that is pyramidal tract, the descending tracts. Okay, if it is affected, the lower motor neurons will take upper hand. There will be what sort of rigidity? Clasp knife. Initially there will be flaccidity, because lower motor neurons, they do not, they have to take some time to take their own action. They will take some time. So after that, what will happen? There will be rigidity, but clasp knife rigidity. That means when the upper motor neurons will affect it, the spinal nerves will create a rigidity which differs from lead pipe rigidity. All throughout, in case of pyramidal tract lesion, you will get all throughout a rigidity. It's a lead pipe rigidity. That means pyramidal tract, extrapyramidal tract. That means basal ganglia lesion. You get late pipe rigidity all throughout. What is the features of Parkinsonism? Rigidity, tremor, rigidity, bradykinesia or hypokinesia. You know, there are some clinical features of Parkinsonism, okay, which affects the basal ganglia, especially the nigrostriate pathway. There is a depletion of dopamine in the nigrostriate pathway from substantia nigra of the midbrain to the basal ganglia in the brain. You know, that is the disease is called Parkinsonism, where we can get the rigidity. But in the upper motor nerve lesion, what happens? If there is an injury in the right cerebral hemisphere, there will be paralysis on the left side of the body. That means upper arm and lower limb will not be functional. Okay, there will be paralysis. So that is called hemiplegia. So that is upper motor neuron, because pyramidal tracts comes down and actually at the level of the medulla it crosses and it goes to the opposite side and it controls the opposite side of the body. So there we can get so we know this is a descending fibers motor neuron. And there is another thing which we can get, there is a hemisection, Brown squat syndrome, hemisection of the spinal cord. That is a functional aspect, and from where we can get, there are so many nerve fibers are coming out. These are called the Cauda Equina. So which looks like the tufts of hairs, which looks like the tail of the horse. So this is I can feel the spinal cord, and there is sudden tapering. So that is called the Conus Medullaris. So I can identify upper and lower end like this. Okay, and here we can find, this is the anterior part and posterior part. How we can the fissure, anteromedian fissure, we can get it here. Hello, fellow. The posterior median sulcus, and anterior one is bulged. This is the anterior horn cells. Anterior horn. This is the anterior horn, and this is the posterior horn. And so this is the anteromedian sulcus. ঠিক ঠিক এটাকে ছিঁড়ে ফেলেছে, তাই জন্য ঠিক মতো লাগছে না। ছাড়, এটাতে ভালো আছে। ওকে, নাও ইউ ক্যান ফাইন্ড দি anterior, এখানে ছিঁড়ে ফেলেছে বলে এটা ক্লিয়ার আছে। Anteromedian fissure, posteromedian sulcus, and here we can find the anterior horn cells and posterior horn cells. Clearly? এই যে দেখো, হ্যাঁ 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 ও হ্যাঁ 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 বলতে থাকবে, হ্যাঁ হ্যাঁ এই তো এবার হ্যাঁ 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 দেখো ভালো করে, you can see. So there we can getting anteromedian fissure and posteromedian sulcus, and posterolateral sulcus is very much prominent. Okay, so this is a posterior root ganglia we will get here. Okay, and similarly this is the anteromedian fissure, and so there are anterior part is bulged. Okay, anterior horn cell, and similarly the posterior horn cell we can get it. Okay, and similarly in the lower end we can get the tapering lower end. You can feel the conus medullaris. And what are these structures? These are the coming out of the we can find the nerve roots and this is a pial matter, that is the ligamentum denticulatum. We can get so many ligamentum denticulatum through by which it is been এই যে এখানে দেখতে পাচ্ছ এখানে রুটও আছে এখানে and we are getting the ligamentum denticulatum also. So there are these the modification of the pia which helps in anchorage of the spinal cord to the vertebral column.